So welcome to this video. In this video, we will do a quick recall of anesthesia questions which have been asked in the NEET PG 2021 exam. Okay. So first what I'll do is I'll just show you all the questions and give their answers. So if you're someone who's just looking for answers to the questions which have been asked, it will be useful for you. And once I'm done with that, I'll give you a small review of each of these questions. Okay. So let me take you to the first question from anesthesia. During the procedure of spinal anesthesia or lumbar puncture, the last structure to be punctured is. So very direct, very straightforward question, and the answer is quite straightforward and simple. The answer is arachnoid membrane. Yes. So this is the answer to the first question, right? Now let me take you to the second question. A patient is undergoing surgery where anesthesia is maintained on halothane. The patient developed severe hyperthermia and muscle rigidity. Which of the following agent would have also contributed to the condition? Your options are D-tubocurarine, saxamethonium, cis-atracurium, and rocuronium, right? So in this question, you know that the patient is on halothane, and after administration of halothane, the patient is going in for malignant hyperthermia. They are talking about malignant hyperthermia and their triggers. The important triggers are inhalation anesthetic agents, and along with that, your depolarizing muscle relaxant, which is saxamethonium or succinylcholine. So answer to this question is succinylcholine or saxamethonium. Again, very straightforward question, very important topic in anesthesia, which is malignant hyperthermia, right? Okay. Now let me move on to the third question. The third question is a 30-year-old male was intubated for conduct of general anesthesia for surgery. The best method to confirm the position of endotracheal tube is. The golden standard for the confirmation of endotracheal tube is end-tidal carbon dioxide measurement or capnography. So your answer is C, capnography. I'll come back and give you a detailed review on all these questions. Now let me move on to the next question. Right. So a young male was given a regional anesthesia with 0.25% bupivacaine. Following the drug injection, he became unresponsive and the patient pulse was not palpable. The best method of management would be, again, they are given the patient with a local anesthetic agent, which is bupivacaine, following which the patient developed toxicity. So in this question, they are asking about the management of local anesthesia systemic toxicity, and the drug of choice for the management of local anesthesia systemic toxicity is intralipid. And you know that the patient is having no pulse means the patient is essentially in cardiac arrest. So obviously we have to give CPR to the patient, and along with that the pharmacological drug of choice would be 20% intralipid, right? So moving on to the last direct question from anesthesia. The image below done for airway management include. Again, very direct, very simple, straightforward question. They have given you one image and probably this is showing head tilt chin lift maneuver. So your answer is head tilt chin lift. Other options I'll discuss in detail once I get into the questions, each of them, right? So these are the 5 direct questions which have come from anesthesia. Now let us do a small quick review of each of these questions once again, right? So this is the first question which has been asked. During the procedure of spinal anesthesia or lumbar puncture, what is the last structure to be punctured? And your answer is obviously arachnoid membrane. So you know that when you start giving the procedure of spinal anesthesia, obviously you have to first puncture your skin, right? You have to first puncture your skin. Once you are done with the skin, obviously the second thing that you are going to have just beneath the skin is your subcutaneous tissue, right? You are going to have the subcutaneous tissue. Now once you are done with the subcutaneous tissue, you enter into the zone of ligaments. The first ligament that you are going to encounter is something which is called as supraspinous ligament, right? So skin, subcutaneous tissue, supraspinous ligament. And following the supraspinous ligament, you are going to have a ligament which is called as interspinous ligament, which connects between the spinous processes. So you are going to have interspinous ligament. So in between the interspinous ligaments, you are going to have the spinous processes. You are going to have the spinous processes like this. So you are going to have spinous processes like this, and your interspinous ligament is going to run in between. Once you are done with the interspinous ligament, again you are going to have the third ligament. The third ligament that you puncture in your spinal anesthesia would be something which is called as ligamentum flavum, right? Ligamentum flavum. So ligamentum flavum is something which comes after the interspinous ligament. Now once you have punctured the ligamentum flavum, then you are going to enter a very small area or a small space, right? Following the space, you are going to have something which is called as the dura. Following something, you have something which is called as the dura here, right? So this is the dura, this is the ligamentum flavum. This space is very, very important. This is a space which is present just outside your dura, and it is called as epidural space. This particular space is what is called as epidural space. So this space is called as epidural space. And following the epidural space, immediately you have something which is called as the arachnoid membrane. And as you puncture the arachnoid membrane, you enter the subarachnoid space where you have the CSF, right? May that be lumbar puncture, may that be spinal anesthesia, your aim is to reach this particular subarachnoid space, right? So when you are doing spinal anesthesia, eventually what are going to do? You are going to make the needle pass through all these structures, reach the subarachnoid space and inject the drug into the subarachnoid space. If you are going to do lumbar puncture, all what you need to do is you just have to reach this particular space and draw CSF from this particular space. So more or less they are both the same procedure, except in the final step where in spinal anesthesia you are depositing the drug, right? So I have told about two important spaces. One space is formed between the ligamentum flavum and the dura, and that is what is called as the epidural space. And one space is present beneath the arachnoid membrane outside the pia membrane. This is what is called as a subarachnoid space. If you are performing epidural anesthesia, you will perform it here. If you are performing spinal anesthesia, you will perform it here, right? There are other relevant spaces as well. What is the other relevant space? Immediately after the dura, just beneath the dura, you have something which is called as subdural space. Now, when you are giving spinal anesthesia, one cause of failure in spinal anesthesia is if you are accidentally injecting drug into the subdural space rather than the subarachnoid space. So that is the significance of space which is present between the dura and the arachnoid, the subdural space, where you can cause accidental injection and failure of spinal anesthesia procedure, right? Now, I'll make it more clear with one more important image. If you look at this particular image, you can see the first structure is skin, followed by subcutaneous tissue, followed by supraspinous ligament. This is the interspinous ligament. Then you have the ligamentum flavum, followed by the dura and subarachnoid space. This structure is this particular thing is very useful. Now, one more question they can ask from this particular concept itself is, what structure is not pierced while you are performing your spinal anesthesia or lumbar puncture? As you can see, all these structures are penetrated, except for the fact that these ligaments, like this is one ligament here, there is one ligament here. This is the posterior longitudinal ligament and this is the anterior longitudinal ligament. These posterior longitudinal ligament and anterior longitudinal ligament are not pierced in spinal anesthesia. This kind of a question has been asked before, right? Now, we are talking about spinal anesthesia, and this particular aspect of spinal anesthesia is about the structures being pierced while we are performing the procedure of spinal anesthesia. And this is more or less true when we are going through the midline approach. We are going to penetrate all these structures when you are going through the midline approach. But you also have one more approach which is called as paramedian approach for spinal anesthesia. The advantage of performing paramedian approach of spinal anesthesia is that you are going to skip certain important ligaments, namely supraspinous ligament and interspinous ligament. So you will go through the skin, enter the subcutaneous plane and directly go to the ligamentum flavum. So how do you do median approach and paramedian approach? Suppose this is your spine and this is the midline here. When you are going through this approach straight, it is called as median approach. If you are taking an approach from here 1 centimeter lateral and going like this, it is called as paramedian approach. The paramedian approach bypasses supraspinous ligament and interspinous ligament, and this is especially useful in old age and people with spinal deformities where your ligaments can be calcified or it might be difficult to access the space through the midline approach. Right. So that was a quick review regarding your first question on spinal anesthesia, and this is a very age-old question, has been asked multiple times over the years. Right. Now let me take you to the next question. Very important question. This is one of the hot topics in anesthesia as well. So here in this particular question, I'll read the question again for you. A patient is undergoing surgery where anesthesia is maintained on halothane. Anesthesia is maintained on halothane, following which the patient developed severe hyperthermia and muscle rigidity. So you are having a pharmacological trigger here which is called as halothane and which triggered a condition which is called as hyperthermia. So a pharmacological trigger behind hyperthermia, it is what is called as malignant hyperthermia. right? So malignant hyperthermia is essentially triggered by two important group of drugs. They are your inhalational anesthetic agents and also your depolarizing muscle relaxant, which is dexamethasone. So what I'm going to do is I'm going to do a small review of this particular condition called as malignant hyperthermia for you. Okay, so let me do a small review of malignant hyperthermia. So what is malignant hyperthermia? What is malignant hyperthermia? So I like to call malignant hyperthermia as a pharmacogenetic condition, or pharmacogenetic disorder. What does it mean? It means that it is a genetic disorder, but it does not come to light normally. It only comes to light whenever there is a pharmacological trigger. So it is a pharmacogenetic condition triggered by certain pharmacological agents, right? So what are the pharmacological agents which can trigger this particular condition? Unfortunately for an anesthesiologist, these pharmacological triggers are anesthesia based drugs. They are either inhalational anesthetic agents or they can be depolarizing muscle relaxants. These are the two important triggers for this genetic condition to become symptomatic, right? Among the inhalation anesthetic agents, you know that there are so many inhalational anesthetic agents. Namely, you are having something which is called as halothane, you have something which is called as N-fluorine, you are having something which is called as isoflurane, you have something which is called as desflurane and sevoflurane. So among all the inhalational anesthetic agent, the anesthetic agent with maximum triggering capacity for malignant hyperthermia is halothane, which was asked in the question itself. So among all the inhalation anesthetic agent, halothane is the worst offender. It causes the maximum chances of your particular malignant hyperthermia. The least chances are obviously seen with desflurane and sevoflurane. These two agents are associated with the least incidence of malignant hyperthermia. Even though they are associated with least incidence, they still can trigger malignant hyperthermia. But when they trigger malignant hyperthermia, they happen after some time, means they produce delayed onset malignant hyperthermia. So they produce something which is called as delayed onset malignant hyperthermia. So which are the agents which are responsible for delayed onset malignant hyperthermia? They are desflurane and sevoflurane. You can expect this question in the future years because so many questions have already been asked in malignant hyperthermia. This has not been asked yet, right? So among the inhalation anesthetic agent, maximum potency is seen with halothane, minimal tendency is seen with desflurane and sevoflurane. Delayed onset is also seen with desflurane and sevoflurane. And when it comes to DMR, there is only one DMR that is in use, which is succinylcholine. Succinylcholine also produces a rapid onset type of malignant hyperthermia, right? So this is about the pharmacological triggering. So now what is the genetic condition that you are having? The genetic condition that you are having is a mutation in one particular gene. There is a mutation which is happening in one particular gene, and that gene is something which codes for a channel which is called as ryanodin receptor channels for calcium. Ryanodin receptor channels for calcium. A gene which codes for this particular protein is affected in your malignant hyperthermia. To understand the pathophysiology of this condition, you should understand the basics of the function of your ryanodin receptor. Okay, so for that I am just drawing a skeletal muscle here. Remember that your ryanodin receptor is a calcium channel which is important in regulation of intracytoplasmic levels of calcium in your muscle cells. Malignant hyperthermia is the condition which affects your skeletal muscles. Please do remember that. Okay. Now, what is the function of ryanodin receptor? Now, what I have drawn here is a schematic picture of a skeletal muscle cell. And you know that inside this particular skeletal muscle, I am having a structure which is called as sarcoplasmic reticulum, SR, sarcoplasmic reticulum. Inside the sarcoplasmic reticulum, what I have is calcium. Now, for muscle contraction to happen, the calcium which is present inside the sarcoplasmic reticulum should reach the cytoplasm. The calcium which is present inside the sarcoplasmic reticulum should reach the cytoplasm. This transfer out of calcium from the sarcoplasmic reticulum into the cytoplasm is done with the help of this ryanodin channel or RYR calcium channel. So what is the function of RYR channel? It regulates the intracytoplasmic level of calcium. Now, you know that if there is increased amount of cytoplasmic calcium, it causes muscle contraction. If there is decreased level of intracytoplasmic calcium, it causes muscle relaxation. So this particular channel plays a very important role in muscle contraction and muscle relaxation. Normally, this channel gets activated only in presence of an excitatory nerve signal. Only in presence of an excitatory nerve signal. So when excitatory nerve signal activates this ryanodine channel, it causes a release of calcium from the sarcoplasmic reticulum into the cell, which causes muscle contraction. This is what is called as excitation contraction coupling, right? Now in malignant hyperthermia, even if there is no excitation signal coming from the body, these anesthetic agents will cause triggering and activation of this ryanodine channel, causing increased intracytoplasmic calcium level, right? So even in the absence of an excitatory stimulus, these anesthetic agents will go and activate your ryanodine receptors, cause increased level of intracytoplasmic calcium, causes unregulated muscle contraction. So this is what is happening in malignant hyperthermia. There is unregulated skeletal muscle contraction. Now what is the consequence of unregulated skeletal muscle contraction? So unregulated skeletal muscle contraction is going to happen because there is a trigger mechanism for your mutated ryanodine receptor. So whenever there is unregulated skeletal muscle contraction, what are the consequences? Now, skeletal muscle contraction requires a lot of energy, and energy can only come from oxygen. So, because you are requiring more energy, there is going to be increased oxygen consumption. Yes or no? Increased oxygen consumption. Now, increased oxygen consumption is obviously present because you are going to have a higher metabolic rate because we want more energy. So your skeletal muscle should undergo metabolism at a faster rate. So there is going to be increased metabolic rate of your particular skeletal muscle because we need more energy for this muscle contraction to happen. Now because of increased metabolism or increased metabolic rate, two things happen. What is the first thing? First thing is metabolism is something which generates a lot of heat inside your body. And that is why, because of the uncontrolled metabolism of skeletal muscle, it generates a lot of heat inside the body, which together contributes to something which is called as hyperthermia. Right? You should understand that 60% of your total body weight is composed by your skeletal muscles. So, increased metabolism of all these 60% body weight is definitely going to contribute to body temperature, which causes hyperthermia. Right. Also, increase in metabolic rate means increased byproduct production as well. What is the byproduct of or end product of your normal metabolism or aerobic metabolism? It is carbon dioxide, right? There is going to be more generation of carbon dioxide because of increased metabolism, and increased carbon dioxide is going to contribute to something which is called as hypercapnia. Now, this is a very important aspect of malignant hyperthermia. Why? Hypercapnia is obviously happening as a result of the pathological process which is happening inside the body. But this factor helps us to diagnose this condition very early in the intraoperative period. Now, we would have attached an end-tidal carbon dioxide monitor inside the patient. And because there is increased carbon dioxide production because of the hypermetabolic rate, there is going to be a rise in EtCO2 value. There is going to be a rise in EtCO2 value, which is probably the earliest identification marker for your condition called as malignant hyperthermia. You know that the normal value of this EtCO2 ranges between 35 to 45. Now, in case of malignant hyperthermia, because of increased carbon dioxide production, these values can even go beyond 100. This is the earliest identification in the intraoperative period. Now, this is itself a question, right? Earliest identification of malignant hyperthermia in the intraoperative period. So, I've told about hyperthermia, which happens as a result of increased metabolism. I've told about hypercapnia, which also happens as a result of increased aerobic metabolism. Now, after some time, what is going to happen? Oxygen will be inadequate. You are having metabolism and contraction at a very rapid rate. The oxygen that we are supplying might not be enough to meet this. So, the cells now will go in for something which is called as anaerobic metabolism. Cells now will go for something which is called as anaerobic metabolism. Now, when the cells goes in for anaerobic metabolism, it produces something which is called as lactate. The end product of anaerobic metabolism is lactate. Now, excess lactate in the body means lactic acidosis is going to happen. So, lactic acidosis is a type of what? It is a type of metabolic acidosis. Yes or no? So, along with hypercapnia, along with hyperthermia, because of increased anaerobic metabolism which is happening inside the body, it results in something which is called as lactic acidosis, which is a type of metabolic acidosis, right? Metabolic acidosis, if you want to know, it is more specifically, it is something which is called as high anion gap metabolic acidosis. Hypercapnia, hyperthermia, metabolic acidosis. The story does not end here. Now, the cells will undergo aerobic metabolism. After a while, the cells will undergo anaerobic metabolism, but eventually all these skeletal muscle cells will die off, will get destroyed. Now, when the skeletal muscle cells are getting destroyed, that phenomenon is what is called as rhabdomyolysis. It releases two important things from the cell into the intravascular compartment or extracellular compartment. It releases something which is called as potassium, so it results in hyperkalemia, right? It results in hyperkalemia. Also, it releases something which is called as myoglobin. You have a lot of that inside your skeletal muscle cell, and because of the release of myoglobin, it causes myoglobinemia, which is increased level of myoglobin inside the blood, and that will translate to increased amount of myoglobin in the urine, which is called as myoglobinuria. And myoglobin is a very, very heavy molecule. Larger amounts of myoglobin coming and accumulating in the kidney can cause kidney failure. So, the patient can go in for acute renal failure. Acute renal failure. So, this is the spectrum of things which can happen when the patient is having malignant hyperthermia. There will be hyperthermia, obviously. There will be hypercapnia. There will be lactic acidosis. There will be hyperkalemia, myoglobinuria, myoglobinemia, and acute renal failure. Everything happens because of increased metabolism which is happening in the skeletal muscle cell. As I told you, please do remember the point. The earliest intraoperative identification of this condition is done with the help of end-tidal carbon dioxide monitoring, right? Now, one more important fact about your malignant hyperthermia. How do you confirm the diagnosis of malignant hyperthermia? You confirm the diagnosis of malignant hyperthermia by a technique which is called as muscle biopsy. So, you take a small bit of muscle, and that is, suppose if the patient survives this malignant hyperthermia during the intraoperative period, you can further confirm that by taking a muscle biopsy. You do a muscle biopsy, take a small bit of muscle. Mostly the muscles which are preferred are your rectus abdominis muscle or your vastus muscles. So, you take the muscle and then you make the muscle undergo one specific test. That test is what is called as in vitro contracture test or caffeine halothane contracture test. In vitro contracture test or caffeine halothane contracture test. What is this particular test? It's very simple. You take the muscle bit outside and you expose this muscle to caffeine and halothane. You know that halothane is a very potent trigger. So, upon triggering with halothane, if the muscle undergoes contraction, it is suggestive of malignant hyperthermia. Yeah. So, this is in vitro contraction test or caffeine halothane contraction test. This is again a question for the future from malignant hyperthermia, right? So, that is about the diagnosis of this condition. Now, quickly discuss regarding the treatment of malignant hyperthermia. The treatment of malignant hyperthermia, obviously we have to take care of the hyperthermia. How much does the temperature increase in malignant hyperthermia? The rate of increase of temperature is 1 degree of temperature rises every 5 minutes. So, this is the degree of rise in hyperthermia or temperature. And how do you take care of hyperthermia? Administration of the patient by cold IV fluids, cold blankets, etc., etc. So, this is what we need to do. But what would be the first step of management of hyperthermia? The first step of management of hyperthermia or malignant hyperthermia would be to discontinue the trigger. For example, the patient might be maintained on halothane or the patient might be maintained on some inhalational anesthetic agent. So, the first thing that we need to do is to stop the trigger. So, discontinue the trigger would be the first thing that you are supposed to do and administer 100% oxygen to the patient. Then, take care of hyperthermia. How do you take care of hyperthermia? By cooling the patient down using ice packs and cold IV fluids. Now, you do have a drug of choice for the management of malignant hyperthermia. The drug of choice for the treatment of malignant hyperthermia is something which is called as dantrolene. Now, this is very, very, very important. Now, what is the significance of dantrolene? before the entry of dantrolene, the mortality rate of your condition or malignant hyperthermia was 60%. Following the introduction of dantrolene, the mortality rate is 1.4%. Now, this is still a significant mortality number, but see the reduction which has happened after the introduction of dantrolene. So, the drug of choice for the treatment of malignant hyperthermia is dantrolene. Again, multiple times asked MCQ question. Now, the dose of dantrolene is, we can give 2.5 milligram IV dose, and this can be repeated every 10 to 15 minutes to a maximum dose of 10 milligram, right? Maximum dose of 10 milligram. So, this is the administration of dantrolene, and this is how you take care of malignant hyperthermia. Obviously, you also have to treat the other conditions, like for example, you took care of hyperthermia, you took care of the specific drug of choice. The patient might also be having acidosis, right? So, you take acidosis, or you take care of treatment of acidosis is basically administration of soda bicarb. That is something that we need to do. Similarly, the patient might also be having hyperkalemia. So, if the patient is having hyperkalemia, you have to take care of hyperkalemia by administration of intravenous calcium. The patient might also be in acute renal failure, and if the patient is in acute renal failure, obviously you have to go for dialysis. Yeah, dialysis. And because of all these things inside your body, you might also have coagulopathies. So, if coagulopathies have happened as a result of this particular condition, we might have to treat the coagulopathies as well. This is the wholesome approach that we need to take when the patient has been diagnosed with malignant hyperthermia. It's an absolute nightmare for an anesthesiologist, right? So, I hope you have got an idea regarding this condition called as malignant hyperthermia. Now, let's move on to the next question, right? A 30-year-old male was intubated for the conduct of general anesthesia. The best method to confirm the position of endotracheal tube is. So, again, a very direct question. This question, the answer is capnography. If you remember my regular classes, I have told the significance of capnography. If you see the last 3 to 4 years questions, definitely one question have come from capnography. Even the last NEET exam also, we have had a question from capnography. So, how can we use capnography for the confirmation of intubation? It's quite simple. Now, imagine that you have intubated correctly, and this is your trachea, and this is the endotracheal tube, right? Imagine that you have intubated correctly inside the trachea. Then, obviously, when you are expiring, the amount that is expired will go through the endotracheal tube, and you will have the capnography monitor here to analyze the expired air. So, in this particular expired air, you are going to have carbon dioxide. Because of the carbon dioxide, you are going to get that particular conventional graph in your capnograph. So, this is how you confirm intubation. You confirm intubation, or the golden standard of confirmation of intubation is capnography. You are supposed to get this graph after you put the tube in the trachea in correct position. One very important thing, you might think that it might be auscultation. We are hearing bed sounds on both sides after intubation, or we might think about chest expansion, etc, etc. No, they are not, because auscultation, chest expansion, everything is quite subjective. So, I am one person and you are a different person. I might have heard the chest sounds correctly, you might not have heard the chest sounds correctly. So, it can vary from person to person. But if you are getting a graph in capnograph post intubation, there is no doubts. It is absolutely confirmatory. That is why it is called as a confirmatory test for endotracheal intubation. Now, there is one very important catch. So, when you are intubating, you can either intubate directly into the trachea like this, or sometimes you can intubate further down and the tube can go into one of the bronchi, which is called as endobronchial intubation. And sometimes you can not intubate. If you have missed something, you might not intubate directly in the trachea. You would have put the tube in the esophagus, which is called as esophageal intubation. Your capnograph also helps to identify promptly regarding esophageal intubation. How does the capnograph look like in esophageal intubation? In esophageal intubation, if you see, obviously stomach does not have any carbon dioxide normally. So, your capnographic tracing is going to look like this. Or sometimes, say, imagine you are intubating a patient after a road traffic accident, and just prior to the road traffic accident, the patient might have had some soda related drinks. Then what could happen is, you might get a small carbon dioxide tracing initially, which will wean off within 6 to 7 tracings. For example, you might get a trace like this: 1, 2, 3, 4, 5, 6, and 7. So, it might look like this. So, initially you might get confused whether this is proper endotracheal intubation or not. This is not. This is something which happens if you are intubating a patient post consumption of carbonated air or carbonated drinks, because you are going to have a lot of carbon dioxide in your carbonated drink. So it is going to produce a pattern like this. So for the confirmation of successful intubation, how many such graphs are required? You need a tracing which consists of at least 7. At least 7 tracing like this with proper morphology is required for the diagnosis and confirmation of your endotracheal tube or tracheal intubation. This is something that I would want to give you as an extra point. This is regarding a confirmation of endotracheal intubation, right? Now let us move on to the next question. Yeah, a young male was given a regional anesthesia with 0.25% bupivacaine. Following the drug injection, he became unresponsive and the pulse was not palpable. The best method of management would be, right? So what are we talking about? So when we are administering a local anesthetic agent like say bupivacaine, we are trying to inject it into certain important nerve endings. One place where we should not be giving local anesthetic agent into is your blood, right? We do not want systemic administration of a local anesthetic agent. If in case we have administered significant amounts of local anesthetic agent into the blood, it can cause systemic toxicity, which is called as local anesthesia systemic toxicity. Now when it comes to local anesthesia systemic toxicity, they are mostly of two types. You can either have a cardiovascular toxicity or you can have CNS toxicity. Now when you're talking about CNS toxicity, what can happen to the patient? CNS toxicity is maximally seen with lignocaine. Now it can also be seen with bupivacaine, but the maximum tendency of CNS toxicity is seen with lignocaine. So we have administered lignocaine maybe here for brachial plexus block or for suturing the patient, or we might have introduced lignocaine into the epidural space. Something we have done, and post administration of lignocaine, what has happened? The patient starts complaining of dizziness. The patient starts complaining of dizziness, lightheadedness, or sometimes the patient will say that the patient is having some visual issues or auditory issues. These are all the things the patient is going to complain to you. These are all subjective manifestations of CNS toxicity. So if these manifestations are there, then you have to be extremely vigilant. What is the first objective sign of CNS toxicity? The first objective sign of CNS toxicity that you can see in the patient is perioral numbness. You have a manifestation which is called as perioral numbness or perioral twitching, right? So you can have perioral numbness or perioral twitching, and this is the first objective sign of local anesthesia systemic toxicity involving the CNS. And following which, what will happen to the patient? The patient will gradually develop GTCS, which is an excitatory phenomenon. So if you see CNS toxicity, the initial manifestations will be excitatory in nature. Why? Because the problem basically happens in your cerebral cortex, and you know that cerebral cortex has got a lot of pathways. It has got inhibitory pathways and excitatory pathways. When local anesthesia agents enter into the brain circulation, it initially blocks the inhibitory fibers, and so as a result, what happens is the excitatory fibers are uncontrolled. It results in excitatory manifestations like perioral numbness, twitching, and GTCS. Over a period of time, your excitatory fibers are also going to get inhibited. So there is no inhibitory, no excitatory. Eventually, the patient goes in for CNS depression, and CNS depression will be manifesting as respiratory depression. So the patient will eventually end up in apnea. So GTCS and then finally respiratory depression. This is what happens in CNS toxicity. And when the patient is in that GTCS phase, tonic-clonic phase, or when the patient is having seizures, your drug of choice would be benzodiazepines. So you are going to treat CNS toxicity mostly with benzodiazepines. And like we say in status epilepticus, if you are not able to control the seizures with benzodiazepines, then your drug of choice for control of seizures would be something which is called as sodium thiopentone. Which is also an anesthetic agent, right? So this is how you manage CNS toxicity, benzodiazepine and sodium thiopentone, right? Also, like in any seizures, we have to take care of airway as well, right? So this is how you manage CNS toxicity. CVS toxicity, again we are talking about nerve blockade, right? So here what happens is the depolarization inside your cardiac myocardium will be inhibited, which causes eventually the patient will go in for sinus arrest and cardiac arrest, right? So what happens in your CVS is that your conduction pathway or your depolarization pathways will eventually be blocked because we are giving local anesthetic agent which causes nerve blockade. So all the conduction system will be affected. Sometimes it can directly result in sinus arrest, and sinus arrest can either progress to something which is called as cardiac arrest, or when the patient is having sinus arrest, your body will or your heart will try to generate rhythm from somewhere else. So it might start generating rhythm from your ventricle, which is called as ventricular rhythm, which can progress to ventricular fibrillation or ventricular tachycardia. So the patient might be in frank asystolic cardiac arrest, or the patient might be having ventricular fibrillation or ventricular tachycardia. Like in this particular patient, if you see this case history here, the pulse is not palpable. So obviously we are talking about cardiotoxicity. The patient will definitely be in cardiac arrest. The patient might be in asystolic rhythm, or it might be in VF-VT rhythm, or as a cardiac arrest rhythms, right? So this is what happens in your heart. Now, when you know that the patient is in cardiac arrest because of a bupivacaine induced toxicity or a local anesthesia induced toxicity, whatever cause of cardiac arrest, we need to give CPR. So obviously CPR will form the first part of your management. And nowadays we are having a newer drug for counteracting. The problem when you are having local anesthesia systemic toxicity and local anesthesia induced cardiac arrest is that it is because of the nerve blockage. The patient is not really having any heart contractions, right? So it is very, very difficult to bring the patient out with just CPR. Sometimes what we need to do is we need to put the patient in a cardiopulmonary bypass machine or an ECMO machine, cardiopulmonary bypass machine or an ECMO machine, so that the patient will have some time till the drug effects wean off. Right? If it is possible, you put the patient in ECMO or you put the patient in CPB, cardiopulmonary bypass machine. And when it comes to the pharmacological management of this bupivacaine induced cardiac toxicity, you do have one drug now, which is a very latest newer drug, which is now considered to be the drug of choice for any local anesthesia induced systemic toxicity, which is 20% intralipid. If you are giving it intravenously, it will go and gather all the local anesthetic agents and remove it from the circulation. That is what it does. This is 20% intralipid, right? So this is about this question. Now let us move on to the last question. The image below done for airway management include head tilt chin lift, inline manual stabilization, jaw thrust, head extension, right? So a very straightforward question. You can see that here this particular arm is used for head tilt and this particular arm is used for chin lift. This is a airway securing procedure. Now, why do you think this is a very good procedure? What is the significance? What is the science behind this procedure? So, when you are doing this head tilt chin lift maneuver, what actually happens is that you are pulling the mandible anteriorly. So, you are pulling the mandible anteriorly. So, when you pull the mandible anteriorly, what happens is your tongue will also get displaced anteriorly. The epiglottis also will get displaced slightly anteriorly. Now, when the patient is having some kind of an airway compromise, you are going to have tongue fall, and sometimes the epiglottis also might close over your glottis. So, when you cause anterior displacement of the mandible, the tongue along with all these structures will be displaced anteriorly, opening up the airway. This is why we do this particular procedure called as head tilt chin lift. Now, when you are doing head tilt chin lift, there is one specific problem that you are having. You look at the head here, it is extremely extended. You are going to have a lot of head extension here. Now, normally if you are having a properly if you are having your neck which is not injured, this is not going to be an issue. You can do this whatsoever. But imagine you are having a cervical trauma as well. Imagine the patient has had an injury here at the neck as well. Then if you do this procedure along with an already existing cervical injury, it can be catastrophic to the patient, right? So you cannot do this head tilt chin lift in a patient with suspected cervical injury. So in that patient, what do you do to maintain the airway patency or open up the airway? You do something which is called as the jaw thrust. So let me show you jaw thrust here. So this is jaw thrust. So nothing here. The provider is standing on the head end of the patient and their fingers are behind the angle of the mandible. And from the behind of the mandible, the thrust is given anteriorly. The thrust is given anteriorly like this. Again, it causes anterior displacement of the mandible. The same story follows. Right? Again, this causes anterior displacement of the mandible and the same story follows. But if you see here, neck is more or less in very neutral position. Yes or no? You see here in head tilt chin lift, you can see how much extension has happened at the level of the atlanto-occipital joint. If you see here, it is more or less in neutral position. So jaw thrust would be your go-to procedure for maintaining airway patency if you are suspecting the patient to have any kind of cervical instability or cervical injury. This is the difference. All these three contribute something to which is called as triple maneuver, but it is very important to understand that head tilt chin lift is normally performed in any patient without any suspicion of cervical injury. Suspecting cervical injury, you want to maintain an airway, you can go for jaw thrust. Right? There is one more option which is maintained here, which is called as, which is mentioned here, which is called as inline manual stabilization. What is that? Inline manual stabilization is this. Now, this is for maintaining airway patency. Jaw thrust is for maintaining airway patency. But if you want to intubate a patient who is having cervical injury, then you do this particular phenomenon called as manual inline stabilization. You can see there are two people here. One person is doing the procedure of intubation, which is at the head end of the patient, and this particular person is holding the neck. If you see, the person who is intubating is causing head extension, is trying to cause head extension. At the same time, this particular person is preventing that by giving a counter pressure. So this person will do just the opposite of what this person does. It is giving a counter pressure at the neck so that the neck more or less remains in the neutral position while he is intubating, right? So this is what is called as manual inline stabilization. Again, we are preventing too much motion of your cervical area. You are stabilizing the cervical motion while the person is being intubated. This is manual inline stabilization. And finally, I just want to show you the normal intubation position, which is otherwise called as sniffing position. So what do you mean by sniffing position? Sniffing position is cervical flexion and atlanto-occipital extension. Right, cervical flexion and atlanto-occipital extension. So if you see this particular image here, we have kept a support here for the head, right? So when you are giving a support here for the head, you can automatically see that the neck area has now become flexed. And then you are manually causing extension here. So there is extension at this particular point. This is atlanto-occipital extension and this is flexion at the cervical joint. How much degree of cervical flexion is required? 35 degree of cervical flexion is required. This itself is a question. This particular position itself is a question. Cervical flexion, atlanto-occipital extension. For intubation, there should be flexion at cervical joint and extension at the atlanto-occipital joint. The flexion degree should be 35 degrees, right? Now, why do you think we are putting the patient in sniffing position? When you put the patient in sniffing position, imagine you sniffing yourself. You know that there is cervical flexion and atlanto-occipital extension. When you are putting the patient in sniffing position, there is one particular phenomenon which happens inside your body. Now, when you are talking about endotracheal intubation, we are introducing the tube either through the nose or through the mouth, through the pharynx and finally into the larynx. So, mouth is like this, your pharynx is more or less going like this, and then you are having your larynx which is going like this. You are having three important axes: oral axis, pharyngeal axis and laryngeal axis. These three run in three different planes normally. But when you put the patient in sniffing position, all the three axes align and you can get a single line here. This is oral axis here, pharyngeal axis here and laryngeal axis here. Everything has come in alignment so that it will be easy for you to intubate. Right? So there is alignment of oropharyngeo-laryngeal axis. That is how you achieve oropharyngeo-laryngeal axis alignment, by using your sniffing position. Again, as I said, this is your standard position when you are trying to intubate a patient. But if you, in case you are suspecting cervical injury, this much amount of head extension, atlanto-occipital extension or cervical flexion is not required or should not be done. In those scenarios, we go for a procedure which is called as manual inline stabilization. Now, please do remember, airway and airway devices are always going to be a hot topic in your exam, because it gives the anesthesia examiner an opportunity to ask a lot of image-based questions, which is the flavor of the time right now. So always make sure that you go through all the pictures in your airway management chapter before you attend an exam, right? So that was my quick review of your NEET PG anesthesia questions. If you have any doubts or if I've missed any question, you can put it up in the comments box so that I can give you answers to that as well. Thank you. you.